So thank you for having me here today, and I'm going to talk to you about how we all make decisions about therapy. It's not how doctors make decisions, but it's how we, doctors and patients and family and everyone together, makes decisions about therapy. And the first thing that you need to know is that there's a long history of therapy in multiple myeloma, and you need to, as a doctor and as a patient, you need to understand it. And to go back, we'll go back 60 years, 1955 in Houston. That's my dad. 5 years before that, the first class of drug that we currently use today in the treatment of myeloma had been reported. And you know it today as prednisone or dexamethasone. But steroids were the first drug that people use, that we still use today, and they provide a temporary relief for the disease. But my dad, when he was at the MD Anderson, introduced another drug that we still use today, and that's called melphalan. And if you've had a stem cell transplant, you would have received a lot of that. And if you received cyclophosphamide, you received the drug that's related to that. And that was in 1962. And this was such amazing news that it made the paper. New drug promising in the fight of cancer in the Houston Chronicle. And my father thought that he was about this close to curing multiple myeloma in 1962. He told me a story about his first patient on a clinical trial of melphalan, and he didn't know how to use the drug back then. He was doing a clinical trial, and he gave the patient melphalan every single day for about, I think, 4 weeks. And then the patient's marrow went away completely, which we know we wouldn't treat someone like that today. But the patient's M spike that you've seen here, that his myeloma protein went way down. And my father thought this was great, and so he actually did that again. And then he got a little bit scared because it took a long time for the patient's bone marrow, normal bone marrow, to come back. This was before stem cell transplants. But that patient's M spike never, ever, ever came back. And unfortunately, they lived in Texas, and he was a truck driver, so he naturally got into a gunfight. And he was on the losing end of that gunfight. But my father was so curious to know if this man had any myeloma left in him that he approached his widow and asked her if he could perform an autopsy. And she agreed, and they looked everywhere in this man, and they couldn't find any multiple myeloma. So he thought if he could just figure out the best way to give this drug, which we now know is to do a stem cell transplant, give a very high dose one single time, that he could cure myeloma. But you may or may not know that for the rest of his career, they made very, very slow progress. And if the progress remains at this rate, we'll cure myeloma in the year 2140, in 140 years. So obviously, that isn't very good. So he would come home to me and he'd say, you know, Leif, if we're going to make any progress in the treatment of multiple myeloma, we need two things. We need to have better drugs, and he thought to get those drugs, we need to have a better understanding of the disease biology. And you may or may not know that both of those things, right about the time he retired, and I started practicing, both of those things happened. We got the drugs that you know today, Revlimid, Velcade, Kyprolis, Darzalex, and there was a dramatic shift in the 5-year survival. That's what I'm showing you here, by the way, on this curve. That was the 5-year survival for people reported in a national database. This is everybody in the country. This isn't just the Mayo Clinic or someplace else. This is everybody. And we quadrupled the rate of increase of the 5-year survival. It was 0.5% per year, and it went up to 2% per year. If we remain on that trajectory, we will cure myeloma in the year 2030. It's not bad.
How do we make it to 2030?
Well, there we go. So I'm going to answer that question for you. But now you'll see that we don't just have those two kinds of drugs, the dexamethasone and the melphalan. We've got 4 other classes of drugs that are active in the treatment of multiple myeloma. the IMiDs, the proteasome inhibitors, the monoclonal antibodies, and panabinostat, which is a histone deacetylase inhibitor. Those are all drugs that have been approved for the use in the years that you see listed there. And so I think if we put those drugs together in the right way, the right cocktail, the right times, we can make a dramatic difference. And if we add some of the new things that are coming along, I think we can shift the curve and do again what we did in the year 2000 and quadruple the rate of increase in survival, and we'll cure the disease in 3 years, 2020, with the use of venetoclax, with the use of bispecific antibodies. I'll talk to you about those this afternoon, that are called BiTEs, the CAR T cells, and checkpoint inhibitors. So I think there's a lot of promise in the treatment of multiple myeloma. And you have to understand, how are we going to figure out how to use all these great tools that we've been given? But if you want to know about someone today, there I've drawn a line, a vertical line at the year 2017. And I'm extrapolating out from the data that we have from the past. And I first made this slide 3 years ago, and so far the points are staying along the curve. But what this slide says is that someone diagnosed this year has a 5-year survival of 71% and a 10-year survival of 64%. Of course, we're not going to know that for another 10 years, but it's certainly promising for the patients diagnosed today. So here's the famous slide that represents a challenge in the treatment of multiple myeloma. And I'm going to take some time to walk you through this. So earlier today, Dr. Fonseca was talking to you about blue balls and pink balls, and he was talking about normal cells and myeloma cells. Well, imagine all of those balls were in fact myeloma cells, but some of them were red and orange and green and blue. Now, why would all the myeloma cells be different colors? The reason is that they are different genetically. They don't have the same mutations in each of those different myeloma cells. There may be one at one time which is predominant, which you see in this patient, the red was predominant when the patient was diagnosed. 72% of the myeloma cells had the red mutations. But then there was a smaller subset that had different, they had a lot of the same mutations, but then they had some different ones that made them unique and made them different color, orange, and another one that was green. So normally when we think about cancer, we think about sort of a Darwinian survival. A cancer cell gets a mutation, and if that mutation makes it fitter, it survives and replaces the cells that came before. And to some extent, that's going on in multiple myeloma, so that there's an evolution of the cancer over time. It can be influenced by the treatments you receive. It can be influenced by the factors of where the cell is in the body. But also, there's probably some cooperation between these different myeloma cells. It may be that one mutation in one clone helps the larger clone to survive. And the play, and they help each other in their persistence. And these clones vary with treatment. So then that's the point of this slide. The patient of Dr. Stewart's had several bone marrow samples taken throughout the course of their disease. And we studied the genes at all those different times to see what was happening with them. And you can see that the patient was initially treated with Revlimid and dexamethasone, and the orange clone tended to grow. So it was somewhat resistant to the Revlimid. And then with even more time, you'll see the green clone at the time of relapse that was only 10% at the beginning went up to 64%. Shown for you right here. And so this clone is resistant to Revlimid. And then we treated that patient with carfilzomib, and the green clone went away, but the orange clone came back again. And we treated with a Velcade combination, and the orange clone got even bigger. And then we gave melphalan here with prednisone and Velcade, and we actually got two different clones that emerged. This orange one continued, but a blue clone that we first only saw here, there's a very faint blue clone, had sort of grown slowly. It emerged, and it turned into a plasma cell leukemia. So the myeloma was no longer just growing in the bone marrow, but was also growing in the blood, and that eventually killed the patient. And so we call this phenomena clonal tides, and the idea that you treat with one drug and one clone emerges, and you treat with another drug, and that the clone that was there before can come back again. And so this has really influenced our thoughts about how we treat patients. And one thought is that when we're concerned about clonal heterogeneity, which is more predominant in patients with high-risk disease than standard-risk disease, then we want to use a combination of drugs to prevent that sort of seesawing. So this is an example of clones where you can, oh yeah?
Does the multiple myeloma part of the cell continue to modify itself?
It does. The myeloma genome is unstable, and and we think that in the high-risk patients it's more unstable, in the low-risk less.
It's like herding cats trying to...
Yeah, that's right. And we often think that all of the mutations that are going to contribute to relapse are probably there at the beginning. And it's just as we suppress the more sensitive cells, the more resistant cells grow out. But here's an example of two clones where you can actually see a difference on the tests that we use to diagnose multiple myeloma. This is the serum protein electrophoresis, and sometimes you see this as a tracing, and you see this as a spike. This band here is albumin, which is the major protein in blood. So here, the patient had two clones, and he was treated with carfilzomib, and this clone went away, but this clone, you see, started to grow just over 14 days. Here's another example where there were two different clones treated with pomalidomide, and that clone went away. This clone kind of stayed the same. Now, I guess one thing I should tell you is that this was that patient of my wife's. That wasn't my patient. And my wife is a PhD, and she treats mice with multiple myeloma. So these are mice that have got multiple myeloma. And the interesting thing about mice is that they're genetically identical. It's like having a twin brother or a twin sister. So you can transplant myeloma from one brother into his identical twin brother. Obviously something we can't do in patients, but you can learn a lot about how the disease works. So here we have two different mice with myeloma, and we're going to transplant this tumor into identical siblings. And we did that into three different identical siblings here, and two different ones here. And you can see the siblings we chose were siblings that already had myeloma. And so we're trying to address the competition between the myeloma in the first mice and the myeloma that's pre-existing in the other mice. And what you can see is that in this case, when we transplanted in this tumor, it stimulated this, yeah?
Silly question, because I'm totally confused.
Oh, well, this is kind of confusing.
I don't get it. Do all myelomas end up cloning?
All myelomas have got what we think of as different subclones.
Okay.
And we think the high risk have got many more different subclones, and the low risk, many fewer.
Okay.
And this just shows an example where one subclone helps the growth of another. So this subclone stimulated that subclone. And same thing happened here. And in this case, however, this subclone replaced that subclone. So they can compete and they can cooperate. And over in this mouse, we see that this was an aggressive subclone, and it got rid of the myeloma that was there before. So one way to cure myeloma is to give a patient worse myeloma.
We're going to have an hour for Q&A
Yeah.
after this.
But-
so thank you.
But go ahead.
Okay, just how much can you infer to people from mice?
Excellent question. So with this mouse model, if we treat it with a drug and it responds, then 73% of the time that drug has been approved for the use of treatment of multiple myeloma. And if we treat it with a drug and the mouse doesn't respond, then 92% of the time that drug has not been approved for the use of multiple myeloma. So I think this is a very, this has the same genetics as what happens in people and has a behavior that's very similar. And obviously there's some things you can do in a mouse you just can't do in a patient. But so in this case, and this is something we worry about a little bit, if we've got a patient who's got very indolent disease, we don't want to stir things up and make it worse with treatment. And that shows the same. And also the question is, how do we decide how much treatment to give? And so here, if we treat with full strength bortezomib, the spike will come down, then it will come back, and we treat again, it will come down, treat again, and it will come down. So full strength bortezomib seems to work very well, but the duration by which it works gets shorter. And that happens to be the same thing with patients in general. Our therapies work well initially, but then as we go further, the duration with which they work is less. But if we use lower doses, that's what the small triangle is trying to indicate here, low doses, then actually we change the biology and the disease can grow more rapidly and grow out of control. And so we want to use the proper dose. We don't want to, you might say, well, you know, drugs have side effects. Why don't we start at a low dose and then slowly go up to a tolerable dose? The reason we don't do that is that can cause resistance. And so we usually try to start at an effective dose and maintain that. And then if we see complications, then lower the dose. You might have wondered why doctors do it that way, and this is the reason. There was a friend of my father's, a very famous oncologist, said that by using lower doses, we were killing patients with kindness. And that's something I think a lot of oncologists have learned in their training. So if we can't use, obviously there's a limit to the dose that we can use. What we can do is we can put different drugs together. And so there you can see a whole bunch of different letters that are strung together here, different three-letter acronyms. Those are different combinations of these three drugs. And as we put them together in different ways, we can see that the response rates gets higher and higher. So you may have heard the use of carfilzomib, lenalidomide, and dexamethasone, or Velcade, Revlimid, and dexamethasone. All of those are giving us very high response rates. And so obviously, if there's a problem to continue to add drugs together, is that it can be expensive, and it might be hard on the patient. So we have to really think about what's the best way to do this. And you saw how we put letters together. I've come up with a string of letters, Sididal-Pobo-Sidep. That's every drug that's been used in the treatment of multiple myeloma given in sequence. Obviously, we don't do that, but I think we've got a lot of good tools at hand, and we have to figure out the best way to use them. So one of them is, in fact, transplant. So you've heard a lot about the novel drugs, but transplant is a very effective therapy, and not just because my dad found melphalan. You can see here, this is a summary of a study where patients received either 8 cycles of Revlimid, Velcade, and dexamethasone, or they got 3 cycles, a stem cell collection, a transplant, and then 2 more cycles. Then they got a year of maintenance. And you can see that if you got the transplant, you had a higher response rate. And you've heard about MRD. This is 1 in 100,000, or 1 in 10,000 cells. The MRD negative rate was higher with the transplant. If you went even more sensitive to 1 in 100,000 cells, it was higher. And the time before the disease came back, the progression-free survival, was longer. So I think looking at this, you'd say it's a no-brainer. Patients should get treated with a transplant. The only caveat is that the overall survival between those 2 groups is the same. So why is it that the progression-free survival is so much longer here, but then the overall survival is the same? And the reason is that we have got good therapy to give patients when they relapse. And so that we're able to salvage the patients that relapse early after transplant. And so should you have a transplant? Well, for many of you, it's maybe in the past. It's not a decision you have to make. But maybe some of you are thinking about it. I think most myeloma doctors feel that you're better off being on this curve than on this curve, even though the survival is the same at this time point. And we think if we can keep the disease from coming back, that maybe it won't come back, maybe it will never come back, and that everything we can do that increases the depth of response and the time the disease stays away is better for the patients. And so we would mostly recommend this. It's worth noting that when these patients did relapse here, most of them got a transplant. So it was really a choice of getting a transplant here or getting a transplant later on. And if your disease will stay longer, why not get it earlier on? So how do we decide on the therapies given all these different choices? Well, we put our heads together, and this is just one slide from a schema we call Emsmart that all of the myeloma doctors at the Mayo Clinic in Rochester, in Arizona and Florida, we sort of put together. And it depends on what's going on with the patient. That's why we have different boxes here. And I'm not sure the specifics are so important as sort of the general schema, which is that if you're taking a maintenance drug like Revlimid and your disease comes back, then we would probably not use Revlimid to treat you. We would use, one of the other drugs in the armamentarium. Same thing if you're on Velcade, then we would give you Revlimid or something like that. And we would basically try and put the combinations together, also thinking about the toxicities of the patient. So if a patient happens to be indolent or frail, we might use Ixazomib instead of, so that's Ninlaro instead of Kyprolis. Or we might use Implicity, Elotuzumab, instead of Daratumumab. And the general thought is we know, or it's been shown in several studies, that when patients relapse, it appears they do better if they get 3 drugs than 2 drugs. So in general, we would put 3 drugs together at the time of relapse. And then, of course, it gets even more complicated. I'm not actually going to go through this slide with you because I don't think the details are important. But as you become refractory to more and more drugs, one of the best options are clinical trials. So patients who are refractory to the standard drugs, we always recommend the first option they go in a clinical trial. And if they don't have clinical trial options, we follow the schema as recommended here. And that's it. Thank you.